Dr. Shakir, thanks for coming back on the show. Last time we had you here, we were talking about breast cancer, and today we're going to turn our focus to men and talk about prostate cancer. At what age should men be concerned about prostate cancer?
What I recommend for most men is at the age of 50, they should have a discussion with their physician about the pros and cons of testing. There's some caveats to that, and if a man is African American or if he has a family history of prostate cancer, I do recommend at the age of 45.
Okay, and are there symptoms?
Sure. With early stage prostate cancer, there's not a lot of symptoms that we get concerned about, but with locally advanced prostate cancer, there could be symptoms of decreased urination, decreased flow of stream of urine, blood in the urine, and blood in the semen. Also, with more advanced cases like stage 4 prostate cancer, you can have bone pain or hip or pelvis pain are usually the most common symptoms that happen.
Let's talk about risk factors and who's in our population is at the greatest risk.
Sure. What I tell men is that there's two separate groups I divide them into, either modifiable risk factors and non-modifiable risk factors. Non-modifiable risk factors are age, ethnicity, and family history. In regards to age, we know that there's a direct correlation with a man's age and development of prostate cancer. Mm-hmm. If a man is 50, he has a 50% chance of prostate cancer. If a man is 60, 60%, 70, 70%, it keeps going up. In regards to ethnicity, we know that African Americans have the highest incidence of prostate cancer as compared to Caucasian or Asians. We just don't know the reason why, but there should be selected as screening groups for earlier ages. Lastly is family history. We know that if a man has a first-degree relative, that is a brother or a father with prostate cancer, they have a double risk of developing prostate cancer. Now, if they have a father, a brother, and another brother with prostate cancer, that increases the risk between 5 to 11 times. We also know, and it's not commonly talked about, but prostate cancer is probably the most genetically charged cancer. There was a Scandinavian study where they studied 45,000 twins, and they tried finding concordance between cancers between the identical twins. And they studied breast, colon, and prostate. And actually, prostate had the highest concordance amongst identical twins. They concluded from that study was that 40% of prostate cancer is likely related to some hereditary factors. There are certain modifiable risk factors that I also mentioned to men. First is diet. We know men that have a high animal fat intake, that is more red meat, 3 to 4 servings per week versus 1 serving per week of red meat, have an increased risk of prostate cancer. Vegetables are a big issue for men, for myself as well. We know that men that have more than 20 servings per week of vegetables versus men that have less than 10 servings per week of vegetables have an decreased risk of prostate cancer. There have been certain vegetables that have been pointed out in people's diet, especially tomatoes that contain lycopene. Mm-hmm. They say that men that have lycopene increase in their diet will decrease their risk of prostate cancer. That was really based only on one study. The FDA then tried to correlate people that have high lycopene levels and low lycopene levels and the risk of prostate cancer, and they really couldn't find a correlation. So the real message that we take home today is that we know that lycopene or tomatoes probably won't hurt you, but I can't tell you how much it helps you. Mm-hmm. There's a couple of other modifiable risk factors, especially minerals and vitamins. We commonly see at pharmacy stores of men's prostate health vitamins. We know now at least that vitamin E and selenium, which is typically promoted to help prostate cancer, was studied in over 32,000 men, and it didn't show any decreased risk of prostate cancer. What it actually did show is that men who take more vitamin E may have an actually increased risk of prostate cancer. So we have to be mindful of how much vitamins we're taking and do the vitamins really help us. There are two other modifiable risk factors I really talk about with men, and that's obesity and physical activity. Mm-hmm. We know that men that have a body mass index of more than 25 versus less than 25 have an increased risk of developing prostate cancer. Also, physical activity. If a man exercises more than 3 hours per week and he's greater than 65, he can decrease his prostate cancer risk by 20 to 30%. Mm-hmm. Now, there are a lot of other factors that come into play with obesity and physical activity, and there's a lot of other studies that may say yes or no for physical activity and obesity and prostate cancer risk, but my opinion is that it surely helps.
Well, and it seems those seem to be the same sort of factors that contribute or help us with other types of cancers as well. I'm
Exactly.
thinking back to the discussion we had last year about breast cancer. It's
Mm-hmm.
a lot of the same thing.
Exactly.
Physical activity,
Mm-hmm.
no smoking.
Correct.
I want to get back to why does the risk increase with age?
Sure. So what happens for a man is that at the age of puberty, testosterone is starting to be secreted, and the active form of testosterone called dihydrotestosterone is starting to stimulate the prostate gland. That happens at the age of puberty, and for a man, he never goes into a menopause like a woman does.
Right.
So that constant stimulation to the prostate gland by testosterone changes the cells over a period of time in architecture. So the longer a man lives, the longer his testosterone is secreted, the more risk of prostate cancer he'll have.
Okay. So we chatted a lot before the show started about the PSA test, because is that the most common test for a prostate cancer?
Sure. There are two screening methods, PSA test and digital rectal exam.
Okay.
PSA testing is actually something called prostate-specific antigen. It's a blood test. This prostate-specific antigen is an enzyme or protein that's actually secreted by the cells of the prostate gland and spilled over into small amounts into the bloodstream. When checked via a blood test, you can see if someone has a lot of it, there's certain disorders that can cause that elevated PSA. Prostate cancer happens to be one of them, but there's also prostatitis, there's also a benign prostatic hypertrophy, trauma to the area, urinary tract infections. So the prostate cancer PSA test isn't perfect. There are some false positives to it.
So if we read in the news, there is some controversy with the PSA screening test. Should it be done? Should it not be done? And there's quite a long story that has to do with the preventative task force study. Can you kind of explain that to us?
Sure. So the United States Preventative Task Force have come out and made a blanket statement and said that PSA screening does not affect a man's mortality for prostate cancer. And they did that for three reasons, based on three studies actually. The three studies are, the first one was an American study published in the New England Journal of Medicine in 2009. They looked at 150,000 men. They said compared men who had PSA screening versus men who did not have PSA screening. What they found was that there was no change in men's prostate cancer mortality. More men didn't die from checking the PSA earlier or even later. There's two distinct problems with that study. The first problem was that 52% of men that should not have had the PSA did. So the study was contaminated. Also what happened was they only followed men for 7 years, not long enough in my opinion. There was two other studies from Europe. The first European study published in the same year right after the American study looked at actually 162,000 men, not as much contamination. They looked at PSA versus non-PSA, and they found that 20% reduction in prostate cancer mortality if you check the PSA earlier. So big difference between the two studies. They also found that you needed to treat 48 men to prevent one man's death. So that was the difficulty with that study, was how do we prove it's enough to treat a man to prevent only one man's death? So there was a third study that was done, and they looked at 20,000 men this time, same European study, and they followed men for a longer period of time, 14 years. And they found that 40% decreased risk of prostate cancer mortality if you did PSA screening. In that study, you had to treat 12 men to prevent one man's death. So the United States Preventative Task Force looked at these three studies, and they've said, no, based on these three studies, we should not do prostate cancer screening. Now, I differ in that opinion. The opinion that I recommend is the same opinion that the American Society of Clinical Oncology recommends. They've made some clinical provisions. They have said, or what I also recommend, is that men that have a life expectancy of more than 10 years should discuss with their physician about PSA screening. Men have a life expectancy of less than 10 years should be discouraged. The tough part comes is, how do you know if they're going to live more than 10 years or less than 10 years? And that's a discussion I think openly a patient should have with their physician. So the blanket statement of no PSA screening, I disagree. I think the discussion needs to be done with the patient's family care provider.
Because actually the test is not where the risk factor is. It's actually the biopsy can have some risk factors.
Correct. So it's not just finding the test being positive, but then the subsequent treatments and diagnosing of the prostate cancer can lead to issues. So the biopsy can cause problems. Not only finding the biopsy, this might have been a low-grade prostate cancer that might have not have caused a problem in a person for many number of years. The treatment may cause problems as well.
Okay. Dr. Shakir, I'm sure like other cancers, prostate cancer has different stages. Can you explain what they are?
Sure. With prostate cancer, I typically don't talk about stage 1, 2, 3, or 4. What we do divide them into is localized prostate cancer and metastatic prostate cancer. Localized, I divide into three subgroups: low risk, intermediate risk, or high risk prostate cancer. Metastatic prostate cancer is when prostate cancer moves outside the prostate gland and it goes into bones or other organs.
Okay. So what kind of treatment options do you have if it's a localized? We'll start with that.
Sure. There's always three options I discuss with the patient: surgery, radiation, or some form of medical or chemotherapy. Now, you could use a combination of the three, you could use one, or you could do nothing. So for localized prostate cancer, what I tell men who fall into a low-risk group, and this is where the discussion lies for the United States Preventative Task Force, is because some men who have localized low-risk prostate cancer are being overtreated. They're having surgery or radiation when they probably should not have been. So the low-risk men, I have a frank discussion about doing active surveillance, meaning watching their PSA levels, meaning repeating biopsies if we need to. So those patients really need to be closely watched. The high-risk group patients under the localized group need to have a discussion with their urologist, radiation doctor, as well as their medical cancer doctor about the benefits of doing surgery versus radiation versus a combination of surgery and chemo or some sort of androgen deprivation therapy alone.
Okay. So in other words, it depends.
It clearly depends. So you need a team-based approach, especially with this type of cancer.
And it is one of the slowest growing cancers, as I understand?
That's partly true and partly a myth.
Okay.
And the reason why I say that is because in comparative to breast cancer, we know in breast cancer about 200 to 250,000 women each year get breast cancer, and about 39,000 women each year die of breast cancer. Comparing prostate cancer, we have about 250,000 men with prostate cancer, and we have 30,000 deaths. So still 30,000 deaths per year versus 39. Not as much as breast cancer, but still men can die of prostate cancer.
So what are some of, if it's caught early, it's a survivable cancer for many. What is the survival rate for early detection? Do you know?
If someone has localized prostate cancer or even locally advanced prostate cancer, the 5-year overall survival is 100%.
Wow.
Now, if you find it in a metastatic setting outside the prostate cancer, outside the prostate gland, the 5-year survival may be 25 to 30%.
Where are some of the, if it's metastatic, what are some of the areas that it typically affects?
The most common area that I get concerned about is the bones.
Okay.
So the first place prostate cancer likes to go to is the bones.
Okay. Well, we talked about some myths earlier. Are there some other ones that you wanted to talk about?
Absolutely. One is that men, as we mentioned, men do not die of prostate cancer, and we know that that's false. Second myth that I tend to have men discuss about is that it only occurs in older age groups. We know that men that are less than 40 have a 1 in 10,000 risk of developing prostate cancer, but between 40 and 59, it goes from 1 in 10,000 to 1 in 38. So clearly, between 40 and 59, there's an increased risk of prostate cancer. So it's not just elderly, 70 or 80-year-old men, it's also between 40 and 59 that it can happen. Vasectomies. Men have commonly approached me and said, if I have a vasectomy, I have heard that increases my risk of prostate cancer. That was initially thought of in the 1980s. There's been many studies to prove that that's not true. So the studies that were done before are weak at best.
So there, as we talk about, we do hear a lot of stuff as consumers, stuff on the internet, stuff about health. I mean, how do we as the consumers sort of, go through all that stuff, and how do you know what's true and what may be,
Sure. There are certain good websites. So when a patient comes to me, I recommend certain websites for prostate cancer. There are certain non-for-profit cancer websites that I recommend patients look at and read information about. So it's not only just looking at websites, but it's also a discussion with their physician. Use your physician as well as use relevant websites, because you're right, you Google prostate cancer and you might find crazy treatments that are available out there. So I think there should be a discussion with the physician as well as looking at relevant websites.
Okay. And when should men start, seeing their physician on a regular basis?
Sure. So outside the realm of prostate cancer, usually I recommend men 30 and above should start seeing their physician for normal health screenings, for cholesterol checks, blood pressure checks. For prostate cancer, it's at age 50 where we get concerned about.
Okay. And your primary care physician will generally start doing those tests?
Correct.
Okay. Let's talk a little bit about some new advancements in treatment and detection. What's new out on the horizon for prostate cancer?
Now, a lot of things haven't changed for localized prostate cancer. For metastatic prostate cancer, there's been a whole slew of new chemotherapy agents that are available. 3 years ago, we used to have 1 or 2 drugs. Now we have about 6 to 8 drugs that are potentially available for prostate cancer. So there are new immune-based chemotherapies. There are new targeted chemotherapies for prostate cancer. So I think that discussion with the patient for metastatic disease has become very common, that we can use different types of chemotherapy like we do for breast cancer. For localized prostate cancer, what they're really looking at and studying is who should be treated and who should not be treated, because there's certain aggressive prostate cancers and non-aggressive prostate cancers. So there's certain genetics that we're looking at with prostate cancers. We're hoping in the next 1 to 2 years we can select patients to say you should be treated, because if you're not treated, their prostate cancer is going to grow. Versus you should not be treated, we can watch you closely, because there's complications to treatment.
Okay. And finally, we know sometimes men are not as willing to go to the doctor to take care of their own health, and it's their wife or their significant other that has to sort of push them to do that. What advice can you give to men and to maybe the wives out there to get their husbands or their boyfriends to get to their doctor?
Sure. I think you have to understand the inherent reason why. So the inherent reason being is because men feel like, one, they're embarrassed to go. And the second reason is we feel like we're strong. We don't need to see a physician. We don't need to be taken care of. So embarrassment and not need to be taken care of are the most common reasons why. What a spouse or a girlfriend can do is 2 things I recommend. One is that explain to them the reason why you want them to go to a physician is because you love them, you want them to be around for a long period of time. So kind of bring them up before you tell them you have to go to the physician. The second way, which commonly works for me, is that my wife will say, I'm scheduling you an appointment. If you cancel this appointment, it's going to be a $50 charge, so you better go to the physician. Lastly, which doesn't work very often, is continued nagging. So I think those 3-tiered approach typically works.
So a little bit of
yes.
nagging, there's a cost involved.
Correct, and bringing them up and saying, we need you around for a long period of time,
right.
You should go to a physician.
Well, thank you so much for coming back on
Thank
the
you.
show. We love having you. Great information that's easy to understand. So
Thanks.
Thank you again.